All right, our final speaker of the afternoon and of today's session is Dr. Leslie Hamilton. Dr. Hamilton is an associate professor with the University of Tennessee College of Pharmacy on their Knoxville campus. Has been there in academia at that campus since 2012. Prior to that, she was a professor with the Auburn University for a few years there as well, where she practiced there in pulmonology and critical care. Here at UT, she practices in neurology and critical care. So please give me a warm welcome to Dr. Leslie Hamilton for your last session of the day on fluid electrolytes and nutrition.
Thank you, Brian, for the introduction. My current practice is neurocritical care, and so I see sodium and electrolyte disorders all day long, and also a lot of my training is in nutrition support and critical care, so we'll kind of do that part at the end, but glad to be here today. Okay, I have no conflicts of interest to disclose at all. And I have kind of an agenda of what we're going to be covering today. Some things I'm going to spend more time on, some things I'm going to go a little faster on, depending on what is most important for you guys to know. But we will be spending a decent amount of time on sodium disorders. Those are some of the most difficult disorders, to making sure everybody understands the different types of hyponatremia and some of the intricacies of hypernatremia. And then we'll be finishing with the other electrolytes, and then finally with nutrition, enteral and parenteral nutrition. Okay, so our first question that we're going to go over, self-assessment question, is about fluids. And so we have a 74-year-old female, comes in with a cough, has a temperature of 102, and is lethargic. And you can start looking at some of her baseline characteristics. You see the blood pressure, she's hypotensive. Her heart rate, she's pretty tachycardic. Urine output is slowed down, white count is up, and so you're kind of thinking, looking like a sepsis picture potentially. You see some renal dysfunction, and she got a 500 cc bolus of normal saline. Her pressure went up a little bit, heart rate didn't really budge, and she has a diagnosis of pneumonia based on chest x-ray. Not really anything that's important in terms of her past medical history. So what is the best treatment option for this patient? I'm going to go ahead and have you guys poll. Should we give her some Lasix, 40 milligrams, albumin plus Levophed or norepinephrine, a liter bolus with D5W normal saline, or a liter bolus with normal saline? So if you guys can throw up cards, great. I see mostly D, and we'll get to a bit more of a discussion about this and talk about the answer in a little bit. But what you need to think about in this patient is, how do we recognize intravascular volume depletion? We talked about her clinical signs and symptoms. We saw her heart rate. We saw her blood pressure. You can look at skin turgor. Those sorts of things are some of the diagnostic criteria for someone who might be intravascularly volume depleted. We also, this is kind of setting us up to think about how, when you give a liter of fluid, depending on what type of fluid, how is it distributed in the body, and why is one type of fluid more effective than another type of fluid? And then finally, what IV fluids can we use that can maximize our intravascular volume? I remember when I was in pharmacy school, and when I still teach this information to my current pharmacy students, people usually groan thinking about how the body is divided up into the intracellular and extracellular compartments. So I'm going to make this hopefully not very painful, and we'll go through it pretty quickly. So if you think of a patient, about 60% is intracellular, and then 40% is extracellular, and then it's further divided into interstitial and intravascular. And this intravascular is our biggest target, because when someone is septic or maybe has hypovolemic shock, that's the target that we're trying to get to, is to replenish that intravascular volume. There are red blood cells in this space, and also plasma and extracellular fluid, and there's a little bit more, about 2 liters of fluid that go along with that to make up your total blood volume of about 5 liters. So if you think of your body like a gas tank, the intravascular volume is what is important and makes you go, per se. And then you guys have seen, I'm sure, many times before the Starling Curve, and looking at the measures of intravascular volume and also cardiac output. And as this is increasing, you kind of get to a level, and then it starts going back down with your cardiac output as well. So this is something that is pretty important to think about in terms of when you're replacing IV fluids, when you're thinking, Is a liter normal saline best? Is a liter of Normasol or a liter of lactated ringers the best? Why is one better than maybe a D5W combination? And so if you think about sodium chloride, lactated ringers, and Normasol. And I do have to ask, who uses Normasol or Plasmolite at their institution? Probably not tons of people. And so I'll give you just a very quick little info about that fluid because it's a bit more expensive than other fluids, but it's a very useful fluid. The sodium content is 140, so it's kind of normal as in what a body's normal sodium level would be. And it has a much lower amount of chloride in it than sodium chloride does, like normal saline does. So if you're seeing someone who gets hyperchloremic metabolic acidosis, Normasol can be or Plasmolite, it's another name for it, very similar, can be a very good fluid for those patients. So you can consider all these three are types of crystalloids. And since the sodium and chloride don't freely enter cells, if you give a liter bolus, you're going to end up giving about 250 cc's or a quarter of that bolus that's going to go into the intravascular space. However, if you might see a provider or physician wanting to do a liter bolus of D5W, only 100 cc's or 100 mLs of that is actually going to make it into the intravascular space. So it helps about thinking, how does dextrose get broken down? Since it's water and CO2, water can go freely across that membrane, which is why only 100 cc's ends up staying in where you want it to, the intravascular space. So going on to colloids, and there's a lot of different types of colloids that we use. It was great hearing our previous speaker talking about, some of the albumin issues and in renal patients, but if you give 500 cc's of albumin, it's supposed to provide 500 cc's of intravascular volume replacement. And there's different types of colloids, so packed red blood cells, PRBCs. If someone's in hemorrhagic shock, you might be using that as your colloid. Albumin is another example. Dextrose and hetastarch have really fallen out of favor, though they are used sometimes just because of the risk of renal failure. But I wanted you all to have a complete list of these. Now, we gave an example previously of 5% albumin, but you might see practitioners using 25% albumin, and it actually is going to expand the volume by 5 times the amount that you're actually giving. So if you give 100 mLs of 25% albumin, it's going to actually give you 500 mLs of intravascular volume replacement. And this can cause redistribution, which actually might end up dehydrating patients in the long term. There's really some specific patient populations that you will use this in. Patients with ascites, so more end-stage liver disease, they're getting paracenteses, removing the liters of fluid, so have a lot of ascites, and also someone who might have end-stage cancer and has pleural effusions and has problems with this, that you really want fluid redistribution to happen from those spaces, then this might be a good option to use. So as I already mentioned, hemorrhagic and septic shock are usually when you're going to see these types of fluid resuscitations happen. When about 750 mLs have been depleted from the body, that's when you start seeing the signs and symptoms of hypotension. People might be tachycardic, and then especially once they have received fluid and get a fluid bolus, then you see that improvement. Like our patient that we had in the previous case, her systolic went from like 72 to 80, so she did have an improvement. They do recommend using a central venous catheter especially when you have large volumes of fluids to replace. That's not always practical and able to happen in an emergent situation in the ER. But if you have a patient, maybe a trauma patient, who needs to get 40 liters of different types of products, blood products, and also fluids, to be able to do that much that quickly, that can be recommended. Also, they do recommend you give a bolus 500 or 1,000 mLs and then watch what happens and kind of do little boluses at a time. So you may give a liter, kind of see what happens, and then give another liter and see what happens. And you might use 500 mLs instead of a liter if maybe you have someone with chronic heart failure or chronic kidney disease or a very small patient. You may start with 500 mLs versus a liter in those patients. So crystalloids are really recommended. They're a lot cheaper than colloids are. Patients can develop adverse reactions to colloids. So there's a syndrome that you may have heard of called TRALI before, T-R-A-L-I, and that's transfusion-related acute lung injury. So patients can get basically acute lung injury and ARDS from colloids, even albumin, but especially with packed red blood cells. So that can be an issue for those patients. And they really haven't found any superiority of colloids over crystalloids. So if you have a cheaper agent that's easier to get and it has fewer potential adverse reactions, that's why you'll see most practitioners ending up using crystalloids instead. If a patient may have received several liters of fluid and they still, they're starting to look puffy, they look kind of like the Michelin man, and they're not able to keep their fluid exactly where it needs to be in the intravascular space. At that point, you may consider giving some albumin at that point to help hold the fluid a bit better in the intravascular space. And then, as we already mentioned, patients who might have very severe edema, like an ascites patient or a patient with really severe pleural effusions, the 25% albumin might be recommended in those patients. And you might see that given with a loop diuretic like furosemide. So it's kind of like a chaser, truthfully, after albumin. So they give the albumin, and then any extra volume that they want to help remove excreted by the kidneys, they will give a loop diuretic for that. So hopefully you guys have never, and this happens sometimes, working in your hospitals and in your pharmacies, if you might see an order, I need a stat liter of D5W half normal saline with 20 a K. That's not a stat order, that's maintenance fluids order. So sometimes if you work in an academic medical center where there's new medical residents there and they may be ordering fluids for their very first time, this can be something that you can help educate them on about whether you're doing fluid resuscitation with, liter boluses, or whether you're doing more of a maintenance fluid like with the dextrose half normal saline combo. The only exception to this, and this is in my intensive care unit that I work in, is we use for our maintenance fluid usually normal saline in most patients, because if someone has had a stroke or some sort of neurological injury, you want to be very careful not to let them get too hyponatremic. So you may see someone getting more normal saline, maybe even lactated ringers or Normasol with that sodium of 140. And this is an important role for you as a pharmacist as well, is to evaluate their IV fluid daily. So I might see someone that's eating and drinking just fine, or maybe enteral nutrition has been started on them, and then you still see they're getting fluids at 100 cc's an hour. That might be an intervention you can make, calling the provider saying, do we really need both, because it can end up fluid overloading a patient. So the question that you might get asked a lot is, how much fluid do you need to give patients? And so I'm going to give you some rules of thumb as we go, because the rules of thumb make it a lot easier to remember kind of when you're coming up with these patients, and also studying for your board, your BCPS exam as well. So for fluid resuscitation, you really are going to give 500 or liter boluses until their signs and symptoms improve. I might need 2 liters. Someone else, a bigger gentleman who's a lot taller than I am, may need 3 or 4 liters. So it really kind of depends on the patient how much fluid resuscitation they may need. Based on a pediatric fluid resuscitation formula, some practitioners will give 1,500 mLs for the first 20 kilos of a patient, and then 20 mLs per kilo thereafter. A lot easier way to remember that is about 30 mLs per kilo. So if you have read the surviving sepsis guidelines before and think about what a fluid bolus is considered, it's usually 30 mLs per kilo in most patients. That also tends to be what a patient's daily fluid requirement is. So for me, it's a lot easier to calculate 30 mLs per kilo than necessarily remembering the formula. Okay, so back to Our Lady, and you guys have already answered this question and did a great job. So almost overwhelmingly, I saw that you all did pick the liter bolus option D with normal saline. Remember that we don't want to give Lasix for this patient. She is fluid depleted. We do not need to give albumin nor epinephrine without trying some boluses of a crystalloid. This is more of a maintenance fluid, and then you guys did great choosing the correct fluid option. Okay, so we're going to move on to plasma osmolality, and this becomes a big problem particularly in a neurologic or traumatic ICU. or even maybe on your floors. I see it a lot with mannitol. So if someone's getting mannitol, you have to be very careful with their osmolality, the patient's osmolality. And this also is really important in terms of fluids. So for you guys working on the floors or in your pharmacies, you may see different things get ordered that they're very, very hypotonic and have a low osmolality, or very hypertonic and have a high one. And depending on the patient, that may or may not be appropriate for them. So you have to be very careful, because too high of an osmolality can cause dehydration, basically drying out of the cells, and a low one can cause swelling. So you want to try to keep it in a nice range, around somewhere between like 280 and 300 is, for most hospitals, normal range for osmolality. So for your normal types of fluids, like normal saline that are isotonic, there's not really any fluid shift, because there's not a difference in the osmotic gradient. But if you have someone who maybe has traumatic brain injury, or even very severe low sodium, so very severe hyponatremia, they may be receiving hypertonic IV fluid, and you have to be very careful to use it only for a particular period of time, and watch their sodium and their osmoles very closely to make sure you're not going up too quickly. Hypotonic IV fluid can be just as bad, if not worse, if the osmoles of the fluid is less than 150, or sorry, excuse me, if the osmoles of the patient are less than 150 milliosmoles per kilo, then it can end up causing hemolysis of the red blood cells. So this can be a problem. Have you guys ever seen an order for quarter normal saline before in your institutions? I see a few hands. And so we're going to talk about some of the problems with quarter normal saline and some solutions that you can suggest to your providers at your institutions if that is recommended. We're going to skip the calculations of the osmolarities, but that is in your book. And then we're going to go on to our next case and then describe some of the different fluids and the different osmolalities that you have. So we have a 72-year-old female with hypertension who started HCTZ 3 weeks ago and has signs of dizziness, fatigue, and nausea. She's also hypotensive and tachycardic, and her sodium is 116. So I'm sure you guys may have seen this in the hospital. You have more of an elderly patient admitted, they just started hydrochlorothiazide, and boom, they come in with a low sodium. What you need to think about as a practitioner is she seizing? No, she's not at this point, but she has some dizziness, fatigue, and nausea. That helps you decide how aggressive you're going to be, because if a patient's in a coma and they're seizing, you're going to push more towards one type of intervention versus another. So based on your guys' thoughts, what would you do for this patient, if you'll show your cards for me? So would you give normal saline at 100 cc's an hour, a 500 cc normal saline bolus, 3% sodium chloride, or 23.4% sodium chloride? I see mostly B's. Great. Okay, we're going to go on and go on to our next question. What is the treatment goal for the first 24 hours in correcting her sodium? And her initial value is 116. 140, 132, 126, or keep her 116 to 120. You guys will show your cards for me as well. I see lots of greens, which is great, and we'll talk about the different rates by which you can increase someone's sodium and what is a safe rate to go up. This is a question, when I recently took my critical care boards that were just offered for the first time this year, there were several questions about how fast you could raise someone's sodium, and I remember there's lots of things about sodium disorders on there. So symptoms of hyponatremia, and this patient, she had the nausea and malaise. Then you start getting down to headache and lethargy, and then 115, then you may see seizures and coma as well. Now, in some patients, they may be a lot more sensitive to this, and so they may have seizures and coma at a level of 120 versus a level of 115. I'm sorry, it looks like maybe you're not being able to find it in the book. I see some people. It's not in there? Okay. Okay. Some of the slides are missing. Interesting. Okay, well, we'll keep on going, and I'll make sure that you get, I just noticed, I see some people have a handout. Okay, online version's correct, I hear. So sorry about that. I just saw people flipping around and wanted to check. Okay, the next question about The next thing to think about in hyponatremia are patients who have severe hyperglycemia. So I will never forget when several years ago, I had a patient who came in DKA, and their sodium was 120, and the physician immediately wanted to start hypertonic saline in this patient, but their glucose was 1,000. So you need to take into account someone's glucose, because you can correct someone's sodium for their glucose, and then it actually ends up being a pseudo-hyponatremia. So that's something that's really important to think about in patients with hyponatremia, what their glucose is. So as a quick review, there are 3 types of hyponatremia: low volume or hypovolemic, normal volume or euvolemic, and then hypervolemic hyponatremia. And if you think about it, I think truthfully the easiest one to think about is probably hypovolemic. Someone may have had nausea and vomiting or diarrhea, they may have gotten a trauma, and so they've lost a lot of volume, so then they have a low sodium from that. Something that you can add to this is patients with cerebral salt wasting. So if any of you have worked with neurological patients who may have a stroke or subarachnoid hemorrhage, they can also experience hypovolemic hyponatremia. Hypervolemic also is not too hard conceptually to think about. Patients with poor kidney function or patients with heart failure, they are fluid overloaded, and so basically their water stores are a lot more, and it's making their sodium look low just because their volume overloaded. And euvolemic is usually the hardest, and a lot of times it's caused by SAADH. And us as pharmacists, if you get a consult, please help look at medications for someone's hyponatremia, which you might get asked. Then there's a lot of different medications that can cause SAADH. So these are kind of our main causes, just as a review. With hypovolemic hyponatremia, what can happen is that a patient who is hypovolemic, their ADH secretion changes. And so once you restore their intravascular volume, then that secretion slows. And so you have to be very careful making sure that you don't correct too quickly the sodium in these patients. Okay, on to the next slide, which is going to answer our questions back. And sorry if these are not in your slides that you have in your book. That you guys were correct in that normal saline is the correct option. This, I want you to think about, this high amount of sodium chloride is really only used for intracranial pressure control in patients with traumatic brain injury, so this really should never be used otherwise. And 3% is an option, but remember, she's not seizing and she's not in a coma, so we can try to do a fluid bolus first. And I think the other obvious thing is you need to stop her hydrochlorothiazide. That's something that's not included in the question, but stop the drug that caused it. Another thing to think about, I work with a lot of stroke patients, and so this example of this, in this case, is someone who's had a recent stroke, is non-communicative, has expressive aphasia, and they're started on enteral nutrition, which is great, and then you see their sodium start crawling up in this patient. So I want us to think about, as we, in a little bit when we get to hypernatremia, about why this happens, because a lot of times it's just because they get their volume dry and volume down. Okay, back to the same slide with hyponatremia. We already talked about the causes of hyponatremia. Now we're going to talk about how you fix them. So for hypovolemic, I think that everyone could very easily agree you need to give them more volume. If you have hypervolemic, you need to restrict what they're intaking and trying to get rid of the underlying cause of the fluid, and maybe if they need dialysis or need diuretics if they have heart failure. And then we're also going to talk about some of the strategies in euvolemic, and then the Vaptans, which we will talk about right now. So the Vaptans are Conivaptan and Tolvaptan. Has anyone in here used the Vaptans before? I'm sure several people probably have. Great. And what they are arginine vasopressor receptor antagonists. And so what they end up doing is helping, they are called aquaretics, so they help patients basically excrete water without all the electrolytes in there. So if you've ever used them before, when I've used them sometimes in patients, I might see a patient pee 6 to 8 liters of fluid, and it's clear as water because they're holding on to all of their sodium and all their other electrolytes. Remember, though, you only want to use this in hypervolemic and euvolemic because it does not make sense to use it in hypovolemic hyponatremia, because in those patients, you want to give them more volume back, not take it away from them. So that's one of the great interventions a pharmacist can make. If you see an order for one of these, help a provider look at their ins and outs and look at the patient and make sure it's the appropriate therapy for those patients. Things to remember is that these drugs, especially Conivaptan, which is the IV form, have a lot of drug interactions. They work on CYP3A4, and so they're with statins and several other medications. There are going to be drug interactions. And even though you're supposed to do fluid restriction with euvolemic and hypervolemic hyponatremia, if you do fluid restriction plus the Vaptan, it can end up making your sodium correct a little bit too quickly. So just be careful with that. Some patients have a more exaggerated response than others. One last thing that I'll say is that kind of goes along with the top part. There's not really any evidence of improved clinical outcomes. It makes us feel better, though, a lot of times to see someone's sodium not 120. You'll see it up at 130 for patients. So if you have someone who comes in with chronic heart failure and they live at a sodium of 118, this is not someone that you're going to want to be really using these Vaptans in, because they're chronically at 118. Even though there is an indication that you can use these, you have to be really careful, because you don't want to kind of upturn the apple cart if that's where someone's normal sodium is for them. So there's a little bit of controversy with that. Okay, we'll finish up with hypertonic saline, and then very quickly we're going to then we'll move on to hypotonic fluid. So hypertonic saline, the main uses are going to be in patients with really severe neurologic injury. Sometimes patients have a symptomatic hyponatremia, and it's usually acute. I had a patient very recently. There's some new oncology drugs that I'm not an oncology specialist at all, but I kind of had to read about them a bit, that can really deplete your sodium and your potassium very acutely. So maybe as some of these new drugs are coming on the market, keep a close eye out for patients that might have electrolyte disturbances from them. Hypertonic saline is not for chronic asymptomatic hyponatremia. So for your patient with chronic heart failure who comes in with a sodium of 118 and has no symptoms, they just happen to have a sodium of 118 that they might find incidentally on admission, this is where you don't want to use hypertonic saline. As we already mentioned, be very careful with patients who also have DKA or very severe, maybe HSS, very severe hyperglycemia, because they probably have a fictitious hyponatremia. And then also with heart failure, you have to think, is this a chronic hyponatremia for them? And you really use your clinical judgment with that, whether you want to use hypertonic saline or not. So if any of you guys work with kidney disease patients, you'll see they'll put patients on bicarb drips a lot. And a problem I've seen at our institution before is maybe with some of the newer providers, they want to do maybe 3 amps of bicarb, so 150 milliequivalents of sodium bicarb, and they want to put it with normal saline. So this is an error that you can help prevent with those patients. Maybe your institution may put it in sterile water, maybe they'll put it in dextrose, whatever your institution's policy is. But that's making sure you're not making a hypertonic solution by accident. So that's just something that you need to keep a close eye out for. So as our question already addressed just a little bit ago, and most of you guys all got this correct, is you really want to have no more of an increase than 10 to 12 milliequivalents in a day for your increase in your sodium. Now, if someone's seizing and their sodium's 105, I had someone with a sodium of